And it's my pleasure to introduce Dr. Yareem Satterwhite, who earned her Bachelor of Science in Chemistry from Belhaven University in Jackson, Mississippi, her Doctor of Pharmacy degree from Midwestern University College of Pharmacy in Glendale, Arizona. She completed her PGY1 pharmacy residency at the VA Southern Oregon Rehabilitation Center and Clinics, White City, VA, in White City, Oregon, and is currently completing a PGY2 psychiatric pharmacy residency at the Salt Lake City VA healthcare system. Her clinical interests include substance use disorders and serious mental illness, with a strong focus on expanding access to evidence-based treatment within the Veterans Health Administration. Dr. Satterwhite has contributed to initiatives aimed at reducing barriers to care, including work supporting syringe services programming and improving access to low-barrier medication treatment. She is committed to fostering a non-judgmental, patient-centered environment for individuals receiving mental health and addiction care. Dr. Satterwhite plans to continue her career within the VA as a clinical psychiatric pharmacist with a focus on addiction and serious mental illness services.
Okay, thank you for the introduction. So today we're going to be talking about non-psilocybin psychedelics and psychiatric disorders. This is a very rapidly evolving area with a lot of excitement, but also a lot of misunderstanding. So my goal is to walk through what the evidence actually shows and what this means for practice. No financial disclosures. All of the products we're going to discuss today are investigational and not FDA approved for any indication. Learning objectives. For the pharmacist, 1, describe the current clinical evidence supporting non-psilocybin psychedelic therapies in the treatment of selected psychiatric disorders. 2, summarize pharmacologic mechanisms of action and key safety considerations relevant to non-psilocybin psychedelics used in psychiatric care. And 3, interpret differences in evidence strength, study design, and clinical readiness among non-psychedelic therapies discussed. And then for technicians, 1, identify non-psilocybin psychedelic agents currently under investigation for psychiatric conditions and the general disorders being studied. 2, distinguish between established therapies and emerging or investigational psychedelic treatments based on the level of clinical evidence presented. And 3, recognize general safety considerations and limitations associated with emerging psychedelic therapies discussed. Here are some definitions and abbreviations that you will see throughout. And I wanted to get started with a question. So if you all can log into Poll Everywhere. So what pops in your head when you hear psychedelic? Okay, trippy, 60s, mind-altering, unpredictable hallucinations. Acid, drugs, dissociation. Yeah, super unpredictable. LSD, okay. Dangerous abuse. Okay, yeah. Thanks, guys. Thanks for going through that. I'm gonna go ahead and switch over. Okay, so lots of different answers, right? And for the most part, when we think about a type of psychedelic therapy, psilocybin usually gets the most attention. But today we'll focus on other emerging agents like LSD, which was mentioned, MDMA, and 5-MeO-DMT. Before we talk about any evidence or safety, it's important to define what we mean by psychedelic. The term was coined in 1956 by psychiatrist Humphrey Osmond and derives from Greek roots meaning mind revealing. This framing was intentional as they are defined as substances that alter perception, mood, and cognition. These substances were not initially viewed as treatments, but as tools to explore mental states. Hallucinogen is an older term, but not always accurate since not all of them cause true hallucinations at typical doses. A newer term you may hear is entheogen, which refers more to the spiritual or introspective experiences. But for this talk, we'll stick with the term psychedelics. These drugs are not new. Most were discovered in the early 1900s, but what is new is how we're studying them now with modern clinical tools and structured therapy models. What's interesting, however, is that none of these compounds were originally designed for psychiatry. Most were synthesized for chemical or pharmaceutical research, and their psychoactive properties were discovered later, often accidentally. And after some early exploration, research largely slowed due to regulatory restrictions in the late 20th century. This is just an overview. I'll go into the timelines of each one as we go throughout the presentation. So at a high level, psychedelics can be divided into two main classes, classic and non-classic. For classic psychedelics, this includes drugs like LSD and 5-MeO-DMT. These primarily act as direct agonists at serotonin receptors, especially the 5-HT2A receptor, which drives the classic psychedelic experience, like altered perception, changes in sensory processing, and sometimes, yes, hallucinations. Structurally, many of these look similar to serotonin, which is why they can bind directly to those receptors. You'll see different subgroups like tryptamines and ergolines, but functionally, they all converge on that same serotonin-driven mechanism. Then we have non-classic on the right, with MDMA being the main one here. MDMA doesn't directly activate serotonin receptors, but instead acts as a monoamine releaser. So it increases levels of norepinephrine, dopamine, and the dominant effect being the increase in serotonin. And it does this by reversing their transporters. So SERT for serotonin, DAT for dopamine, and NET for norepinephrine. So the effects here are very different. Instead of perceptual changes, you get increased empathy, emotional openness, and reduced fear. There is some overlap. Both ultimately involve serotonin, but the key difference is when you think about classic, think about direct receptor activation. When you think non-classic, indirect monoimmune release. So classic changes how you see the world, and non-classic changes how you feel about it. All right, now that we divided it into classic and non-classic groups, this slide gives a quick side-by-side of the three agents we'll focus on today, 5-MeO-DMT, LSD, and MDMA. Each of these differ in a few key areas, onset, duration, and experience. So for 5-MeO-DMT, it has a very rapid onset, usually within minutes, and a relatively short duration, often under an hour. Despite that short duration, the experience is very intense and is often described as more existential or ego dissolving rather than visual. So, clinically, this raises questions about whether a very brief but intense experience could still produce meaningful psychological change. LSD has a much slower onset and a much longer duration, typically 8 to 12 hours. The effects here are more perceptual and cognitive, including changes in sensory processing, time perception, and meaning making. Here, the therapeutic model tends to focus more on deep processing over a prolonged session. And then MDMA has a moderate onset and duration, and the experience is very different. Again, instead of those perceptual changes, it's more emotional and relational with increased empathy, emotional openness, and reduced fear, which is why it's being studied more in conditions like PTSD, where engaging with difficult emotions is a core part of treatment. So even though all three of them fall under psychedelics, they produce very different types of experiences, leading to different therapeutic environments within psychiatric conditions. So I want to briefly highlight overall harm of some substances. This figure evaluates substances based on a combination of harms, including physical, psychological, and social effects. The total score reflects cumulative harm, combining both harm to the individual and harm to others. So we see substances, they're at the bottom, like alcohol, heroin, and cocaine. They rank among the highest in overall harm, whereas psychedelics, which I've highlighted in red, including LSD and MDMA, tend to fall much lower on this scale. To further showcase this, this slide separates the harm into the two categories. So harm to the individual using the substance off to the left, and then harm to others or society off to the right. This helps clarify why some substances rank higher overall. For example, looking at alcohol, it has the highest overall harm score, with a big contributor being impact on others, including accidents, violence, broader societal costs. Psychedelics have lower harm to others, and their risks are more concentrated in the individual experience, so more harm to the user. But this doesn't mean psychedelics are without risk, and this data doesn't account for interpersonal risk that can arise in altered states. Now that we looked at relative harm scores, it's important to understand where that harm actually comes from. With psychedelics, we see both medical and psychological risks. So, acute psychological distress like anxiety and panic is typically caused by those overwhelming experiences, which can then precipitate psychosis in vulnerable individuals. With 5-MeO-DMT, we see more respiratory distress. LSD, we see risk of ongoing and persistent psychological side effects due to that longer duration. And MDMA stands out for higher risk of physiologic toxicity and misuse potential. It's also important to highlight contextual harms, including boundary violations and sexual exploitation, which aren't captured in traditional drug harm scores but are critical patient safety concerns. Most of these risks are tied to either the intensity of the experience itself, a patient's underlying risk factors, and the environment in which the drug is used, which is why in clinical trials, these therapies are delivered in a very controlled, structured setting with screening and trained clinicians present. So when we think about harm with psychedelics, it's not just about the drug itself. It truly is about the interaction between the drug, the person, and the environment. Building on that, I want to focus specifically on toxicity and addiction, which are often the first concerns that come up with any psychoactive substance. In general, psychedelics, including the three we're talking about today, have low addiction potential compared to substances like opioids, alcohol, or stimulants. This is largely because they don't strongly activate the brain's reward pathways in the same way, and they don't tend to produce compulsive patterns. Compared to these, MDMA carries the highest risk overall because of its additional dopaminergic activity. Regardless, overall, there is low addiction potential. However, low addiction potential does not mean no risk, especially outside of controlled or therapeutic settings. Where we start to see more meaningful differences is in toxicity, and this varies by agent. MDMA carries notable physiologic effects. So I'm talking hyperthermia, increased heart rate and blood pressure, and sometimes electrolyte abnormalities like hyponatremia. Another effect may be risk of serotonin syndrome, which may require a washout of SRIs. These are the types of effects that require active monitoring in clinical trials and therapeutic settings. In contrast, classic psychedelics, so LSD, 5-MeO-DMT, they tend to have less direct physiologic toxicity and primarily carry psychologic risks, anxiety, panic, confusion, perceptual disturbances. So that was a lot. So big picture, MDMA, physiological, LSD and 5-MeO-DMT, psychological. Again, harm is often driven by the interaction between the drug, the patient, and the environment, and it just depends on the compound. So that leads us to our next question. So this is a technician response question. Which of the following psychedelic agents was discussed in this presentation as being investigated for psychiatric disorders? MDMA, LSD, 5-MeO-DMT, or all of the above? Okay. Okay, we got MDMA, LSD, and all of the above. Okay, I'm gonna switch back. So answer here is all of the above, right? All three of these agents are being studied in psychiatric disorders, including PTSD, anxiety, depression, and other mood disorders. So now that we've gone through an overview of the three psychedelics I'm going to be talking about, I'd like to start with the one with the most developed clinical evidence, MDMA. So MDMA, or methamphetamine, is a synthetic compound structurally related to amphetamines, which is important when we think about some of its physiologic effects. You might recognize MDMA more commonly as ecstasy or Molly, particularly in recreational settings like the rave culture. However, again, MDMA's primary actions are not to cause hallucinations or perceptual distortions. Instead, its effects are more emotional and relational, which is why it's being studied in conditions like PTSD, where the ability to engage with difficult emotional content without becoming overwhelmed is critical. As promised, I'm going to go through a timeline of each of the substances, starting with MDMA. So MDMA was first synthesized in 1912 by Merck, originally as an intermediate compound, not for psychiatric use, but rather as a substance to help control bleeding. It wasn't until much later, around the mid 1900s, that pharmacologic testing began, followed by early human studies. In the late 1970s and early 1980s, MDMA started to be used by therapists as an adjunct to psychotherapy, which is really the first time we see it being explored for its emotional processing effects. However, around the same time, recreational use increased and MDMA became associated with the name ecstasy, which led to its classification as a Schedule I substance in 1985, which significantly limited research. Then, starting in the early 2000s, research began to re-engage, largely driven by organizations like MAPS, or the Multidisciplinary Association for Psychedelic Studies. And more recently, we've seen progression into phase 3 clinical trials, including MAP1 and MAP2 studies, which I'll go into. I want to briefly touch on pharmacokinetics. So MDMA is typically administered orally with an onset of about 30 to 60 minutes and a duration effect around 4 to 6 hours. This moderate duration allows it to be used in extended structured therapy sessions. It also has nonlinear kinetics, meaning that increases in doses can lead to disproportionately higher plasma concentrations, which is important when we think about safety and dosing. So big picture for MDMA, moderate onset and sustained duration. And then touching on the mechanism of action, MDMA primarily acts as a monoamine releaser, increasing norepinephrine, dopamine, and serotonin by reversing their transporters. Again, the dominant effect is the effect on serotonin. So this leads to increased emotional openness and empathy, reduced fear response, and changes in how emotional information is processed. Looking at the brain, MDMA decreases activity in the amygdala, which is responsible for fear and threat processing. So essentially, it allows patients to engage with traumatic material without becoming overwhelmed by fear. It also increases levels of oxytocin along with cortisol and prolactin, which may further contribute to feelings of trust and emotional connection. So big picture for the big three: serotonin, emotional openness; norepinephrine, vitals and arousal; dopamine, mild euphoria. Okay, that leads us into our next question. Which mechanism best explains the primary therapeutic effects of MDMA and MDMA-assisted therapy? A, potent 5-HT2A receptor agonism causing hallucinations. B, NMDA receptor antagonism producing dissociation. C, monoamine release through serotonin transporter reversal. Or D, dopamine receptor blockage reducing psychosis. All right, so I am seeing mostly C, and that's correct. Yeah, remember, MDMA acts primarily as a monoamine releasing agent and with dominant activity occurring at CERT, increasing serotonin, and also norepinephrine and dopamine. But this contributes to the emotional openness, reduced fear response, and enhanced therapeutic processing. For A, potent 5-HT2A receptor agonism is the primary mechanism of classic psychedelics like LSD. MDMA does not primarily produce hallucinations. And then NMDA receptor antagonism is the primary mechanism of something like ketamine, not MDMA. And then dopamine receptor blockage is the mechanism of antipsychotic meds, typically, not MDMA. So, MDMA has been explored in a variety of areas, including PTSD, anxiety, particularly related to serious illness, depression, substance use disorders, including alcohol use disorder, and even conditions like eating disorders. So, there is a broad interest. However, the strength of evidence is not the same across these conditions, and most of these are still in early phase or exploratory research. Where we really start to see the most developed evidence is in PTSD. Phase 1 primarily focused on safety and pharmacologic effects, really showing tolerability of MDMA and a reduction in PTSD symptom severity. Phase 2 trials further establish a risk-benefit profile within controlled settings and where MDMA-assisted therapy really started to take shape. More recently, phase 3 randomized controlled trials, including MAP1 and MAP2, have continued to show PTSD benefits with MDMA. There are also ongoing studies looking at durability of response and long-term safety. So overall, this isn't just early or exploratory research. This is a therapy that has moved through the full clinical trial pipeline into late phase development. Despite this, the FDA has not approved MDMA-assisted therapy, which I believe is likely due to the overall limitations of the trials and then some, which I'll get into. So why PTSD? PTSD is a psychiatric condition that can develop after exposure to a traumatic event or repeated trauma. It affects about 6 to 8% of the United States population, with higher rates in certain groups like veterans. First line treatment includes trauma focused therapies such as cognitive behavioral therapy. However, about 35 to 47% of patients do not respond adequately. So there is a significant unmet need for additional options. Again, MDMA's effects allows for reduced fear and increased emotional openness, which may help patients engage with traumatic memories in a more tolerable way. So this is probably the most important study we'll discuss today. A phase 3 randomized placebo-controlled trial evaluating MDMA-assisted therapy in patients with moderate to severe PTSD. This was meant to replicate findings from the early phase 3 trial, MAP1, on a larger scale. So MAP1 did all of the same things, but with fewer patients, and MAP2 wanted to replicate these findings of the MAP1 trial with just more patients. So participants ultimately received either MDMA plus therapy or placebo plus therapy within a structured therapeutic setting. This included multiple therapy sessions with controlled dosing and monitoring. The primary outcome was changes in PTSD symptom severity using CAPS-5, which is a validated clinician-rated scale. Secondary outcomes included measures of functional impairment and overall clinical improvement. So overall, this is a pretty well-designed study using validated measures in a structured setting, which strengthens the reliability of the findings. So starting with the efficacy outcomes, MDMA-assisted therapy resulted in significant reductions in PTSD symptom severity, improved functional outcomes, and a higher likelihood of no longer meeting diagnostic criteria for PTSD. So again, this is not just statistical improvement. This reflects clinically meaningful change. One important point to note is that many participants underwent psychotropic medication washout, including SSRIs like sertraline and fluoxetine, prior to treatment. So this is relevant because SSRIs can blunt some of the subjective and neurochemical effects of MDMA. So SSRIs can block SERT, which is that transporter that MDMA needs to actually work. So this raises questions about how these results might translate to patients who remain on antidepressants in real-world settings. Now shifting to safety outcomes. As expected, MDMA was associated with physiologic effects, including increases in blood pressure, heart rate, and body temp. The adverse events were generally transient, meaning they occurred during or shortly after sessions and resolved without long-term complications. These were anticipated based on its mechanism and were closely monitored during treatment sessions and considered manageable overall. And importantly, psychiatric safety outcomes were also closely monitored. Psychiatric adverse events were reported, but were generally transient and did not persist beyond the treatment period. Importantly, there was no increase in suicidality, psychosis, or mania compared to placebo, which is especially relevant given concerns that psychedelics could worsen psychiatry symptoms. One important consideration is not all psychiatric adverse events are necessarily attributable to MDMA itself. Trauma-focused therapy, where patients are actively processing these traumatic experiences, can also lead to temporary increases in distress, anxiety, or emotional intensity. So some of these reported psychiatric events may reflect the therapeutic process itself rather than a direct pharmacologic effect of MDMA, which may also explain why the placebo arm is also high. So, bringing this all together, MDMA assisted therapy resulted in clinically meaningful and statistically significant reductions in PTSD symptom severity compared to placebo plus therapy. It also led to improvements in functional outcomes and a higher likelihood of patients no longer meeting diagnostic criteria for PTSD. These findings were consistent with prior phase 3 data, supporting the reproducibility of the treatment effect. In terms of safety, MDMA assisted therapy demonstrated a manageable safety profile in a carefully screened and monitored population. So, overall, this study provides some of the strongest evidence to date supporting a novel treatment approach for PTSD. The study had several strengths. It's a phase 3 randomized double-blind placebo-controlled trial, which is chef's kiss gold standard for evaluating efficacy. It also replicates findings from earlier phase 3 trials, which strengthens confidence in those results. And it included diverse trauma etiologies in patients with moderate to severe PTSD, increasing relevance to real-world clinical populations. There are also limitations of the study to consider. This was conducted in a highly controlled therapeutic environment with extensive screening and monitoring. Patients with conditions like bipolar 1, psychotic disorders, or significant medical comorbidities were excluded. The psychotropic medication washout may limit generalizability to real world patients, and there is still limited long term safety and durability data beyond the study follow up period. So while the results are promising, they should be interpreted in the context of these limitations, particularly when considering how this might translate into routine clinical practice. That brings us to our next question. So, which safety consideration is commonly monitored during clinical administration of MDMA? A, increased blood pressure and heart rate, B, kidney failure, C, severe respiratory depression, or D, hypoglycemia. So I am seeing mostly A. Good job, you guys. Yeah, MDMA causes sympathomimetic effects, including increased heart rate and blood pressure. Remember, it resembles amphetamines, which would make sense for the increased blood pressure and heart rate. These are carefully monitored during therapy sessions. For B, kidney failure is not a typical acute safety concern. For C, severe respiratory depression is more commonly associated with something like opioids or sedative hypnotics, not MDMA. And D, hypoglycemia is not recognized as a primary adverse event of MDMA therapy. So overall, MDMA currently has the strongest level of clinical evidence in this space, particularly for PTSD. But now we're going to shift to LSD, where the evidence is still emerging. LSD, or lysergic acid diethylamide, is considered a classic psychedelic. Other names include acid or L, especially in recreational settings at music festivals or for personal or spiritual exploration. It's a synthetic compound originally derived from ergot, which is a fungus that grows on rye. LSD's story is a little more complex compared to MDMA. LSD was first synthesized in 1938 by Albert Hofmann, but its psychoactive effects weren't discovered until later in 1943 when he accidentally ingested it, an event often referred to as Bicycle Day because he went on a trip. This marked the beginning of the interest in LSD's effects on perception and consciousness. In the following decades, LSD was actually studied as a psychiatric tool, including use as an adjunct to psychotherapy and even as a model for psychosis. In the late 1960s, LSD became widely used by hippies who protested against the Vietnam War. So the government basically said you're protesting against the Vietnam War because you're on LSD. So that shift from clinical research to widespread recreational and cultural use significantly changed how this drug was perceived, and as a result, LSD was classified as a Schedule I substance, which largely halted research for several decades. Most recently, there has been a renewed interest in studying LSD, this time using more rigorous clinical trial designs and controlled settings. LSD is typically administered orally with an onset of about 20 to 90 minutes and a long duration of action, 8 to 12 hours. This long duration is important because it requires extended, closely monitored therapy sessions, which can be more resource intensive compared to MDMA. It's also important to note that LSD is dosed in micrograms, which reflects its very high receptor affinity, particularly at those serotonin receptors. So even at very small doses, it can produce significant effects. So the key takeaway here is that LSD has a slower onset, significantly longer duration, and a high potency, all of which impact how it's used in clinical settings. Again, I'll briefly touch on mechanism of action here. LSD primarily acts as a potent partial agonist at the 5-HT2A receptor, which is responsible for its classic psychedelic effects. It also has activity at other serotonin receptors, as well as some minor effects on dopamine receptors, which makes it crucial to avoid in patients with schizophrenia. The activity on those receptors leads to altered sensory perception, changes in how meaning is assigned to experiences, and disruption of typical thought patterns. LSD also increases glutamate signaling and cortical network activity, which may contribute to increased cognitive flexibility and changes to perception. And this is where the potential therapeutic relevance comes in. Rather than primarily targeting emotional fear responses like MDMA does, LSD may help patients reframe thoughts, reframe perceptions, and meaning. This is why it's being explored in conditions like anxiety and mood disorders. There's also emerging interest in how these mechanisms may influence pain perception. So, similarly to MDMA, LSD has been explored across a wide range of potential psychiatric and neurologic conditions. This includes anxiety, mood disorders, including depression, ADHD with emerging interest in low dose or repeated dosing approaches, and even pain related conditions such as cluster headaches and migraines. However, unlike MDMA, LSD still doesn't have one clearly established lead indication. Anxiety probably has the strongest modern evidence, but overall, the strength of evidence across these areas is still limited and variable. Much of the data comes from small studies, early phase trials, or emerging clinical investigations. So, one of the key studies evaluating LSD assisted therapy looked at patients with anxiety associated with life threatening diseases like cancer, Parkinson's, or progressive autoimmune conditions. So, mainly anxiety revolving mortality. So, this was a randomized double blind study comparing LSD assisted psychotherapy with 200 micrograms of LSD compared to an active placebo, so still LSD, but at a dose of 20 micrograms rather than 200. This is important in psychedelic trials to help maintain blinding. This again all took place in a controlled settings, and again, the drug was used as part of a therapeutic model, not as a standalone treatment. Primary outcomes included changes in anxiety using validated scales such as state anxiety and trait anxiety. State anxiety is how anxious someone feels in the moment, and trait anxiety reflects a patient's baseline or more long term level of anxiety. So, looking at both helps capture immediate effects and more sustained changes. So, looking at the outcomes, LSD assisted therapy was associated with reductions in both state and trait anxiety compared to the active placebo, but the active placebo still had some noted improvement. So both immediate anxiety and baseline anxiety levels improved. This study also reported large effect sizes, suggesting a meaningful treatment effect within this population. Importantly, these improvements were sustained at the 12-month follow-up without evidence of symptom rebound, which suggests a potential for durable effect, which is particularly interesting given the limited number of treatment sessions. In terms of safety, LSD assisted therapy was generally well tolerated in this controlled setting. However, as with other psychedelics, these findings are limited to carefully screened and monitored patients. So, bringing this all together, LSD assisted therapy was associated with clinically meaningful reductions in anxiety symptoms, including both state and trait anxiety. These improvements were sustained at the 12-month follow-up, suggesting potential for durable effect. However, the evidence remains early phase and limited and is not sufficient to establish definitive efficacy. So overall, these findings support continued clinical investigation, but are not yet practice changing. Strengths of the study include design. It was a randomized double-blind study with an active placebo. It used validated outcome measures. It also included a long-term follow-up demonstrating sustained effects over 12 months, and it evaluated a clinically meaningful population, patients with anxiety related to a serious illness. Limitations included the small sample size, which limits statistical power. They studied like 12 patients. It focused on a very specific population, which may not apply to broader psychiatric conditions. Finding remains a challenge, even with an active placebo, since the subjective effects of LSD can still be distinguishable at lower doses. This is a phase 2 pilot study not designed to establish definitive efficacy or detect rare safety events. So while the findings are promising, they should be interpreted as preliminary and hypothesis generating only. So beyond the studies we just discussed, there is ongoing research exploring LSD across a range of potential applications. This includes continued investigation in anxiety and depression, as well as interest in areas like ADHD and pain-related conditions. There's also exploration of different dosing strategies, including lower or repeated dosing approaches, and efforts to better understand therapeutic protocols. There are also phase 3 trials underway, particularly in anxiety related conditions. These trials are focused on confirming efficacy in larger, more diverse populations, further evaluating safety and tolerability, and helping define standardized dosing and therapeutic protocols. But overall, much of this work remains early phase and exploratory. So now a shift into 5-MeO-DMT, which represents an even earlier stage of research compared to both MDMA and LSD. 5-MeO-DMT stands for 5-methoxy-NN-dimethyltryptamine and is classified as a classic psychedelic. It can be found naturally in certain plants and in the secretions of the Buffo alvarius toad. It's often referred to as toad venom or buffo, especially in ceremonial settings or retreats. So when you see those cartoons or shows where they're licking the toad to get a high, that's what this is. 5-MeO-DMT has been used in indigenous and ceremonial contexts, often for spiritual or introspective purposes. It was first synthesized in 1936 as part of a broader research into tryptamine compounds. It was primarily studied in a chemical and pharmacologic context rather than being widely explored in psychiatry at the time. So, for a long period, there was relatively limited formal clinical development or structured research. More recently, there's been growing interest in studying 5-MeO-DMT in controlled research settings, particularly for its potential effects on mood, anxiety, and well being. So 5-MeO-DMT has a very rapid onset, typically within seconds to minutes, depending on the route of administration. It also has a very short duration of action, often lasting 15 to 45 minutes. So compared to LSD and MDMA, this is a much more compressed experience. This short duration has led to interest in whether therapeutic effects can be achieved in a much shorter treatment session. It's primarily metabolized by monoamine oxidase A, which is important because people might combine it with an MAO inhibitor. And those effects can then be prolonged and even further intensified, which has implications for both safety and use in certain settings. Like other classic psychedelics, 5-MeO-DMT acts on serotonin receptors, primarily 5-HT2A. However, it also has strong activity at the 5-HT1A receptor, which may contribute to its unique effects. This combination is thought to produce rapid and intense alterations in consciousness and experiences often described as ego dissolution or loss of self boundaries. Compared to LSD, the effects are typically less visual and more internal and immersive. And this intensity, combined with the short duration, has led to interest in whether it can produce rapid psychological effects in a very brief session. However, the intensity of the experience often raises concerns and considerations around tolerability and patient selection. The emerging research for 5-MeO-DMT consists of the most preliminary evidence we'll discuss today. Most of the current research is focused on ego dissolution, which is the temporary loss of the sense of self, altered consciousness, as well as potential effects on mood, anxiety, and PTSD-related symptoms. Unlike MDMA and even LSD, 5-MeO-DMT does not yet have randomized controlled trials showing efficacy for psychiatric disorders, and findings are largely based on small studies or naturalistic settings. A lot more work is needed to define its role in clinical practice. One of the key studies evaluating 5-MeO-DMT aimed at evaluating its effects on mood, anxiety, and overall well-being. This was a prospective observational study, which included individuals who had used 5-MeO-DMT already, often in naturalistic or observational settings, rather than a controlled clinical population. So these were patients already using 5-MeO-DMT, and they just voluntarily joined the study. So this reflects a more real-world use rather than a standardized clinical sample. Participants completed assessments before and after their 5-MeO-DMT experience, often within a structured but non-medical setting. In many cases, the compound was administered in the form of vaporized toad secretions rather than a standardized pharmaceutical formulation. This is important because the exact dose and composition can vary, which makes standardization and interpretation more challenging. Dosing is typically measured in milligrams, but can be difficult to control precisely in these settings. The study evaluated changes in depression and anxiety symptoms, as well as measures of well being and life satisfaction, and also looked at the relationship between ego dissolution and psychological outcomes. So, overall, this was an early phase observational study using patient reported outcomes to explore potential therapeutic effects. Participants reported reductions in depression and anxiety symptoms and improvements in overall well being and life satisfaction. One of the more interesting findings was that the degree of ego dissolution was associated with greater improvements in psychological outcomes, so the anxiety and depression. So, this suggests that the intensity of the subjective experience may play a role in the therapeutic effect. These improvements were observed relatively soon after the experience, suggesting a potential for rapid effects. The outcomes are compelling, but because this was observational, it was non standardized, and it didn't have a control group, we can't really conclude treatment efficacy. It's also difficult to determine how much of the effects are due to the drug itself versus other factors such as expectations or the setting. Altogether, 5-MeO-DMT use was associated with improvements in mood, anxiety, and overall well-being. These effects may be related in part to the experience of ego dissolution and altered consciousness. However, the evidence is observational and preliminary but does not establish causality. Strengths include it reflects real-world use, which can provide insight into how these substances are actually experienced outside of clinical trials. It evaluated multiple domains: anxiety, mood, overall well being. It also explored the relationship between ego dissolution and outcomes, which adds an interesting mechanistic perspective. For limitations, this was an observational study without a control group, which limits the ability to determine causality. Participants were often self selected, which may introduce bias. The use of non standardized formulations, so the toad secretions, introduces variability in both dose and composition. And there is also limited long term follow up, making it difficult to assess durability of effects. So, this is an area of high interest, but still at a very early stage of clinical development. Current studies are focused on further evaluating the effects of 5-MeO-DMT on mood and anxiety disorders, PTSD-related symptoms, and overall well-being. There is also increasing interest in studying 5-MeO-DMT in more controlled clinical environments rather than those naturalistic settings. This includes efforts to develop standardized formulations and more consistent dosing and administration protocols. Researchers are also continuing to explore factors like ego dissolution and subjective experience and how they relate to therapeutic outcomes. But overall, this is still very early stage and more research is needed. Okay, going into some more questions. Which of the following psychedelic therapies is currently FDA approved for psychiatric treatment in the United States? A, MDMA assisted therapy, B, LSD assisted therapy, C, 5-MeO-DMT therapy, or D, none of the above? So I'm seeing mostly none of the above, which is correct. Again, these therapies remain investigational despite promising research findings. Okay, going into the next question. Which non-psilocybin psychedelic assisted therapy currently has the strongest level of clinical evidence for treatment of a psychiatric disorder? A, LSD assisted therapy for generalized anxiety disorder. B, MDMA assisted therapy for PTSD. C, 5-MeO-DMT for depression. Or D, LSD microdosing for ADHD. So I'm seeing mostly B, which is correct. MDMA assisted therapy has completed multiple phase 3 randomized control trials in PTSD. So MAP 1 and MAP 2, MAP 2 kind of replicating those findings on a much larger scale. For A, LSD trials remain small or early phase, and 5-MeO-DMT evidence is mostly observational or early phase clinical trials. Okay, next question. A 40-year-old veteran with severe PTSD has failed trauma-focused cognitive behavioral therapy and several antidepressants. He asks whether MDMA-assisted therapy is available for treatment. Which statement best reflects the current evidence and regulatory status? A, MDMA-assisted therapy is FDA approved for PTSD. B, phase 3 trials show benefit, but the therapy remains investigational. C, MDMA can be prescribed off-label for PTSD in outpatient clinics. Or D, evidence for MDMA is limited to case reports and observational studies. So I am seeing mostly B, which is correct. Phase 3 trials demonstrate clinically meaningful reductions in PTSD symptoms. However, MDMA-assisted therapy is not yet FDA approved and remains investigational. MDMA-assisted therapy is not FDA approved for PTSD treatment. For C, MDMA is a Schedule 1 substance and cannot be prescribed for medical use outside of approved research protocols. And for D, evident or MDMA-assisted therapy has been evaluated in multiple randomized controlled trials, including phase 3 trials, providing substantially stronger evidence than case reports. Okay, so some key takeaways. Non-psilocybin psychedelics are being actively studied for psychiatric disorders, including PTSD, anxiety, and depression. MDMA-assisted therapy currently has the strongest evidence with replicated phase 3 trials demonstrating clinically meaningful reductions in PTSD symptoms. LSD research remains early phase, with small controlled studies suggesting potential benefits for anxiety and mood disorders, but limited clinical evidence. Safety profiles differ across compounds, so with MDMA, we saw greater physiologic toxicity risk, and for classic psychedelics like LSD and the 5-MeO-DMT, primarily psychological risks. and all therapies remain investigational and require structured therapeutic settings, extensive screening, and trained clinicians. These are my references. And here's the code. I'll take any question, or I guess the code is next, but I'll take any questions.
Excellent job, Dr. Satterwhite. I'm not seeing anything in the chat.
Okay, I will go ahead and share the code then. Is that okay?
Oh, yeah. Go ahead and share the code, and now
Okay.
one did just pop up. So I'll read that for you. Which of these therapies do you feel is the closest to being FDA approved?
If I had to pick one, that's a good question. I would probably say MDMA assisted therapy just because it does have the strongest clinical evidence and it's gone through the clinical pipeline and all of that. So there are phase 3 trials. It shows durability. It shows reproducibility. I think it's more of a progression issue. And not only the progression issue, but it's also resource intensive, right? We have to have these therapy models and we have to make sure we have clinicians present. The patients are there for 8 hours at every time for all the therapy sessions. So it's just very resource intensive. I think that's the biggest limitation for FDA approval. Yeah, good question.
Is the VAMC currently involved in studies of any of these psychedelics?
Good question. Not that I'm aware of. Um, I think if they were to be studied or if they were to come out, facilities like the VA would be like one of the last to implement them, just because we are federal and government funded.
Excellent. Well, hopefully everyone got the code here. And if you have any additional questions, but yeah, fantastic topic and great review.
Thanks, everyone.